Colokannya aja, yang buat ke mereka yang mana? USB-C atau SDMI?
But like we had Nairobi, then you need to have that one.
Yeah.
Ini Mbak.
John, what's easier for you for Q&A? Do you want to do it here? Or do you want to just have this standing?
Wait. Yeah. Oh. No, I think it's reverse. In the Zoom is the this one. Right? Like just the one this.
Nanti berarti harus standing ini ya.
Kita sebab ini nanti bisa gerak-gerak ngikutin.
Tadi umur tulisannya mana? Oh, you can try. Nyoba dulu. Yes, all good.
Oke.
Berarti ini yang buzzer yang buzzer ke SEO zoom aja. Soalnya dikasih screen zoom aja tadi. Ini otomatis masuk sini. Gimana sih, Pak?
Iya, tadi tenang.
Dikasih screen zoom aja.
Mau dicabut? Mau diganti dong? Nggak usah.
Tapi nanti harus nampilin CV dulu. Saya.
Harus sambil CV.
Oh, udah maju.
Harus sambil CV.
Ya, ini stop share yang ini stop share.
Langsung aja ya. Ini kan udah sharing ke Zoom, dia cabut itu aja. Iya, jadi nggak cabut.
Betul. Betul, Pak. Itu tuh di sini aja. Ini di sini aja. Benar.
Bener kan?
Jadi beliau nanti apapun tinggal share screen
Iya.
aja.
Udah
Betul.
bisa.
Jadi ini nggak perlu dibuka. Gitu maksudnya.
Berarti sekarang kan yang ini dulu dong yang backup.
Kasih pamflet. Tapi ini di stop share dulu boleh nggak, Pak?
Boleh.
Karena kita nampilin CV dulu di sini kayak.
Mungkin stop sharing.
Oh, yeah, we can hide it. Tadi di gini nih. But we will have like introduction video. Okay.
Before, yeah.
So we should be maximizing.
Yeah.
Di stop share dulu aja. Delapan apa ya? 4 kemarin sudah sampai di mana?
Udah mulai.
Belum. Udah. Go. Sini.
Share screen-nya pakai ini. Apa nih? Maksudnya tinggal share screen.
Iya.
Udah punya link Zoom-nya belum?
Udah ini udah buka Zoom-nya.
Iya, itu tuh udah buka Zoom-nya, astaga. Sangat ricu kan.
Santai. Sudah.
Ini tidak ada itu. Boleh ada di situ dulu dong.
Tapi kan
Nanti
dulu.
dipersilakan.
Tetap.
Coba baik. Ini Mbak Nini.
Iya. Langsung kan, nanti langsung kan share screen ini langsung ini toh.
Yang ini.
Ini kan.
Screen-nya gini caranya Mbak. Ini screen. Ada otomatis ngapusnya.
Sekarang aja kok.
Kelihatan di Zoom kan?
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good afternoon and warmest greetings to all participants, distinguished speakers, and professors. Welcome to the guest lecture on recent advances in infectious disease modeling and its application for public health policy. Today's lecture is presented by Master of Public Health Program in collaboration with the Department of Statistics, Epidemiology, and Population Health, and also Center for Tropical Medicine, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. Ladies and gentlemen, my name is Rizky Ajinda as the Master of Ceremony for today's lecture. And first of all, we would like to express our gratitude to all participants who have joined with us, both in the theater room and also virtually through Zoom meeting. Today, we are truly honored to have our inspiring speakers from South Sea Hope, School of Public Health, National University of Singapore. Please allow me to introduce them all. The first speaker is Professor Alex Cook, and the second speaker is Dr. Swapnil Mishra. Welcome, Prof. Alex and Dr. Swapnil. And ladies and gentlemen, for the lecture session, we will be facilitated by Dr. Vika Oktaria, MPH, PhD, as our moderator. Dr. Vika is the head of Department of Statistics, Epidemiology, and Population Health. Dr. Vika teach as an academic teaching staff in Universitas Gadjah Mada. Dr. Vika has expertise in epidemiology, pandemic preparedness and surveillance, waterborne, foodborne, and also vector-borne disease surveillance. Now, Dr. Vika also takes part as the principal investigator in wastewater surveillance for pandemic prevention project. Ladies and gentlemen, maybe we can start the lecture session. And for this session, we will give it to our moderator. Please welcome Dr. Vika.
Thank you, Mbak Kiki. Good afternoon, speakers, college faculty member, student and also guests. Welcome to today's sessions for the guest lecture, recent advance in infectious disease modeling and its application for public health policy. So as we aware that infectious disease remain a major health challenge and especially for the public health. And infectious disease modeling has a crucial role in helping understanding the disease dynamic, such as targeting identifying high-risk populations. It also helps to predict future outbreaks and also evaluating public health interventions as well as to informing public health policy. So, for example, during COVID pandemic, we use statistical modeling to help to make decisions around the lockdown, vaccination strategy, and also the hospital search planning. So in terms of the decision making itself, statistical modeling also help to provide quantitative evidence on the likely consequences for every decision in public health. And today we are very fortunate and privileged to have guests from South Sea Hook, if I'm not mistaken, South Sea Hook, School of Public Health, From National University of Singapore, we have two guests, Professor Alex Cook and also Dr. Swapnil Misa. And we're gonna discuss about how to advance statistical modeling and applications, especially for real public health challenges. And I would like to briefly introduce the first speaker from Alex Cook, who will talk about 30 minutes on the academic and also government academic and government partnership in public health modeling. Prof. Alex, he is an expert in statistical modeling, infectious disease and public health, and has extensive experience as a consultant for the Singapore Ministry of Health, especially during COVID. He also the vice dean for global health in the School of Population in National University of Singapore, and he has directed multiple epidemiological centers and has authored for more than 240 publications, which is very impressive. And so I would like, without further ado, I would like to invite Prof. Alex to give a brief lecture about us and sharing about his experience in statistical modeling.
Terima kasih. Terima kasih. Very lovely to be back here in Yogyakarta. As mentioned, I'm a professor at National University of Singapore, but also for this week, I'm a visiting professor here at UGM. So really quite an honor to be here. I also have an appointment with Singapore's Communicable Diseases Agency as a senior principal project manager, which is quite cool. So I'm going to talk to you about academic government partnerships, and I can talk for a long time about this. So you'll stop me when you want me to shut up. Okay, so I want to start by talking a little about some work that I did during the pandemic. So I was very busy during COVID, and I put on quite a lot of weight as well. And mostly what I was doing was helping to inform our government policies. But I was called to do other things as well, taking advantage of the fact that I knew quite a bit about the situation and research on COVID. And so our deputy president for research asked me to help review proposals and projects that other faculty from my university wanted to get funding for. And so I remember one review that we did of a project. This was by colleagues from engineering, so not from Salisbury Oxford Public Health. And they had come up with a great idea that would revolutionize contact tracing. Contact tracing, very important for controlling the pandemic. And so what their great idea was, in Singapore, if you've ever been, we have a card that you can use on the MRT or the bus system, called the EasyLink card. And that records when we tap in and when we tap out of our buses and our metro system. And so their idea was they could take this database with millions and millions of EasyLink records, and you could use that to help with contact tracing. Our deputy president liked the idea, he funded it. A year later, they came back to present their work, and they said that yes, they could speed up contact tracing, find a lot more cases this way. And so as I was asked to review it, to make sure that the funds would be used to do useful applied work. So I asked them two questions about the project. So the first was, have you spoken to anyone from the Ministry of Health, the contact tracing teams, about this project, right? So they've been working on it for a year, they got a big lot of data, then they were going to publish a paper. But have you spoken to anyone from MOH? I'm like, no. We've not spoken to anyone from MOH. We're going to wait until we published our paper, and then after it's appeared in the journal, we're going to send it over to MOH. Maybe it'll be useful for them then. By which point, we won't be doing contact tracing anymore, because 6 months or a year it takes to get from publication until actually it appears in the journal, right? So they were not interested in trying to change practice at all. All they cared about was their paper. Second question, I asked them. So when I bought an EasyLink card, I didn't show my ID. I'm not linked to the card. How can you actually do contact tracing with this? And they were like, oh yeah, we didn't think about that. But never mind, it's just proof of concept. It's not necessarily like for real contact tracing. So we had gone from it was going to revolutionize our contact tracing for controlling the outbreak to it was purely a proof of concept. for academic purpose, but not for practical purpose. So this was very common with all the projects that I was reviewing, from projects done outside of my school of public health. And fundamentally, I think that academics are sometimes liars. We love to say that our work is important for policy. You see it in all sorts of journal articles, our work is important for policy. But actually, it's usually not. It's usually purely for academic research. Here's some examples that I have taken from, I think, PLOS One or one of the other PLOS journals. I pulled out, did a search, and I got all of the times when someone said that the work was important for policy. And I bet that none of them checked with a policymaker before they made the claim that their work was important for policy. You cannot just unilaterally, as an academic, say your work is important for policy making. You can say it's a good piece of academic research, but it's for policymakers to say, is this work important or not? So, as I say, academics are often liars. But nevertheless, I think that the work that my center does in the School of Public Health, I think it is important for policy. But should you believe me or not? So I'm going to give you a little bit of evidence to support this. So as a result of the work that we did, we got our certificate from our president saying thank you very much for all the work we did. Here is our colleague Bo Dickens getting from the Prime Minister at the time the certificate. I have a little medal in my cabinet. It's like for the work that we did during COVID. So really, I think that the work that we did was important for policy making. And I've been thinking for some time about what makes academic work useful for policymaking, and how do you build that relationship between academics and policymakers in order to make sure the work is actually useful. But it won't come about by chance. So I give you an example. This is some work that our colleague Anna Clapham did. I helped out with it. It was the week of Christmas to New Year of 2021. The Omicron wave had just started. We'd gone through a big Delta wave, our first big wave in Singapore, and the Omicron wave came along, and they were wondering whether we could relax the control measures or not, or was this going to completely overwhelm our healthcare system? So over the week of Christmas to New Year, we worked with Ministry of Health. We were on the phone almost every day, talking about all the data we could find about Omicron and co-developing a model of what the Omicron wave would look like. This is the forecast that we gave them on the 31st of December. And you can see the points there. That's what actually happened over the next few months. So our forecast was bang on perfect. And the Prime Minister saw this forecast. This was one of the things that was used to hold off on relaxing social distancing measures in Singapore until we had gone past that way, because we could see how bad it would be, and we could see how long it would take until we could start to go back to normal. Okay, so I want to talk to you a little bit about motivators for working with government. I've been working with our government in Singapore since 2011 or so, as you know, 2009. And so over this time, I've reflected about what they want and what we want, and what the difference is between what they want and what we want. I think you need to know that, otherwise a relationship will not work. So we're going to consider two archetypes, an academic and a policymaker. What is a policymaker? Actually, who is a policymaker? We talk about this term a lot, but actually it's a very vague term. The Prime Minister, I don't think is a policymaker, a decider, a decision maker, but usually he or she will not be the one who actually develops the policy. The policy will be developed at a lower level, directors and their teams within the Ministry of Health. So it could be someone who maybe has a background, maybe an MPH from UDM or from NUS, and they're working in the government and trying to take scientific evidence and inform policies in a scientific way. Okay, so we have different hopes and desires and ambitions. We think about research in different ways. Do policymakers like research? Yes, I think they do. My experience has been they like research, but they like useful research. They don't care about useless research. Interesting blue sky work, not so interesting. For them, they care about useful work. For us, We care about cool work because cool work is what's going to get published in the best journals. That's a value statement. In the highest impact journals. So that can be sometimes a clash if the useful work is not necessarily cool work. How about timelines? So this is going to sound kind of stupid, but of course, a policymaker wants to have the evidence before they make a recommendation to government. There's no point you come a week later once the policy has been made, or a year later when the policy has been made. But for us, we work on academic time. We want to work to high standards because we get judged on the quality of our work. So we want to spend extra time thinking about how to make it as good as possible, even if that means it's no longer as useful. So we also can clash about control. So my experience has been that policymakers like to have control of the process. They want to put rules in how you can use the data that they give you to avoid you doing things which clashes with what they want, or to avoid data being misused. They're worried this is the data of their voters, of the public, so they want to protect that data. Whereas for us, we want as much access as possible, not because we're greedy, but because we want to check things. We always want to see what if something changed over time, or what if it's different for men and for women, or for high SES and low SES. We want to check these things, and we can only check that if we have more granular data. I find policymakers want to have control over the narrative as well. They get quite anxious if something appears in a newspaper from our research and they haven't seen it yet. And then minister calls and they have to explain to the minister, what is this thing from the National University of Singapore? Whereas for us, we take it as a leap of faith that we should have academic freedom. We should be able to publish what we want when we want it. And that also can clash quite a bit. So you can see there's lots of situations where what they want is different from what we want. And that can make the relationship hard to work. Another thing is that we actually speak quite different languages. So I like to call what they speak policies of what we speak academic. We have an annual meeting with the Permanent Secretary and Director General of Health, and we have to have rehearsals for our faculty members because our professors don't know how to speak like normal people. They will show odds ratios with 4 decimal places, they will show confidence intervals and p-values, table with like 100 numbers on it, policymaker give up already. Right? So we need to change the way that we speak if we want policymakers to understand the key messages. Otherwise, we're not communicating properly. Okay. So despite all of these clashes, I think that nevertheless, we can make a romance happen between government and academia, because there are actually some things where the interests can be aligned. I said before, government likes to have, at least Singapore government, likes to have research because they can point to it and say, we are following the science. The scientists in the School of Public Health or wherever, they provide evidence to support the policy. Our policy is scientific. They like that. They love it when the research that we do is aligned with what they want to do anyway, or something they've already decided. So they did it before, or they're planning to do it already. They don't like it so much if it's different from what they did already, because then it shows that they made a mistake before, and they get defensive. We like working with government because it gives us funding. Most of our funding in our school comes from the Ministry of Health, right? Not come our students. Students do pay some of my salary, yes, but it's mostly coming from MOH. And like I said before, we like to claim that our work is important. And how better to do that than by actually informing policy? Then yeah, our work is important. So I think that you can have this romance, but it requires that we think about having a win-win relationship. Cannot be win-lose, otherwise no relationship will happen. This is why if I go and ask for data and there's nothing in it for them, then the data never comes to me. Right? It will only come if they will benefit and we will benefit. Right, cool. So do we have anyone who's Chinese? No, no. Okay, that's great. So I'm going to make up some stuff then. So this is Guanxi. We gave a talk in India, and I said all sorts of nonsense about this because no one in the room can understand. So this is, I think, is really important, and I believe it applies outside of Chinese settings as well. Guanxi. What is this? So this is basically about the network of relationships that you build up professionally with people. It governs how you interact, how you cooperate with each other. And so when you have Guanxi, when you build up that relationship, then things will happen that wouldn't happen otherwise. So in a relationship in a country in which trust is primarily through relationships rather than through joint activities, Guanxi is very important. So we work hard to cultivate Guanxi with our government in Singapore. There are a few ways that we do this. So one is that where possible, we try to co-publish with them. The people that we work with in the Ministry of Health, they're doctors, or they've got an MPH, or they've got a PhD, right? Actually, for them, publication is important. It's not very important. Like for me, it's very important. For them, yeah, it's nice to have. It shows that they're still active in their research. So I can co-author a paper with some of them MOH. They're more likely to support it getting published, get approval from upstairs to make it be published, than if it's just me and my team from the university. Even if the money is not coming from our partner in MOH, a letter from them can help to activate funding because it shows that this is useful work. To cultivate relationships, we try to help in emergencies. And the example I'm going to give later is an example of that. If they ask me for help and I say no, okay then. But next time if they ask me for help and I'm still saying no, then at some point they're not going to want to work with me anymore. Right? So instead, it's good to try to help out when an emergency comes, because then they will feel reciprocal that they must help you out later when you ask for data or money. We work hard to make sure that we have good communication channels. Obviously, this is a lot easier in a country with 6 million than with 200 plus million. Yeah. And how many islands? 70,000 or something? A lot, right? Yeah. So, so for us, we work hard to ensure that communication is not solely by email or correspondence to the office. I have 40 or 50 people from MOH on my WhatsApp contact list. And so when there is an emergency, they can WhatsApp me and say, hey, bro, can you help with this? And we'll try to help. And then we have joint appointments. So I said before, I have a joint appointment with the Communicable Diseases Agency. Supposedly 1 day a week, I'm supposed to be there helping out. A lot of the senior people from MOH will also have an adjunct position with our school, because we're the national university. It's natural for them to want to have an appointment with us. And that means that they get to call themselves a professor, because they are professing sometimes. And it makes them feel more favorable to working with us. So there's a purposeful way that we have gone about trying to build this relationship. So I want to come back to the one I mentioned about helping during emergencies. So I mostly do infectious disease modeling, but in 2018 or 2019, I got a call from who's now Deputy Director General of Health saying, Alex, we need your help. Someone is going around advocating for electronic cigarettes to be legalized in Singapore using modeling, but we don't understand it. Can you help us to understand it? So the context of this, Philip Morris is a big tobacco manufacturing company. They also produce electronic cigarettes. They're getting really into that because they think that's the future for nicotine. And they had funded consultants, gave a lot of money to this private consultant company to develop a model to look at what the health effects of allowing vaping to be used in Singapore. So Singapore, about 10% of the population smoked traditional tobacco. And at the time, vaping was illegal. Illegally imported from Malaysia, for example, but it wasn't allowed to be vaped openly in public. And so they were going around all of our public hospitals giving presentations about why vaping would be great if we were to legalize it, including to our own National University Hospital, much to my shame. So we did a review of this, we critiqued their model, we found a lot of problems with it. We gave that MOH. We also critiqued it to our Ministry of Law, Attorney General Chambers. And that was used to justify why to hold off and not just to go and legalize it. Let me try to explain very briefly, because you're mostly public health audience, what the problem with their model was. We say cheap in Singapore, so it's going to sound very cheap, very abstract and difficult, but let me try to explain. Okay. So they used a closed cohort. So you'll know from epidemiology, cohort study, you take people and you follow them up over time, right? So simulation-based closed cohort, you take simulated people and you follow them up over time. But no one comes in. They'll come in as an open cohort. If no one comes in as a closed cohort. And so they started with people aged 15 up to 85 or 90. So they take the population of older teenagers and adults and they age them and they have them experience things like starting to smoke, stopping to smoke, starting to vape, stopping to vape. Now, what is the possible health benefits of vaping? The argument, I don't understand, don't completely agree, but the argument is that it is better to vape than to smoke. Therefore, if someone is a smoker now and they switch to vaping, then they'll still be harmed, but the harm will be less. The downside to vaping, the argument is someone who was never going to smoke because it's only for old men in Singapore, then they might start vaping because it's for cool teens. And therefore they start vaping, they've gone from no risk to a higher risk, and potentially to start smoking later. And so they go from low to very high risk. So there's then a potential benefit and a potential cost to allowing vaping. Now, the benefit is primarily later in life. So older smokers, someone who's in their 30s or their 40s, switching to vaping, then for the rest of their life, they will get a protection maybe. The harm is at that short period of life at the beginning, when you're a teen and you see your friends vaping, so you want to vape too. Okay? So there's not a symmetry there, it's different lengths of time. The taking a closed cohort means that something which prevents initiation will, like for example, tobacco tax rise, right? Then it's only going to get a small amount of person years to have an effect. Something which helps cessation is going to have a large number of person years. Right? So vaping the harm will not look so bad. The benefits will look very good because this is very small, that's where the harm is. This is where the benefit is very large. Right? So by making a closed cohort, they artificially make it look better for vaping. What they should have done is have an open cohort. New teenagers come into the population of vapers, potential vapers every year, and they get exposed to vaping and therefore start vaping and have health impacts later. So we explained this to Ministry of Law and Ministry of Health, and then we developed our own model to try to fix this problem. So we've been working for a long time on building a demographic model of the country, which allows us to roll out health policies and see what the effect might be. So extremely briefly, I'll just explain how we did it. So we co-developed with MOH. We said, what are the policies that you're interested in for nicotine control? And we implemented those within our model framework. So some of them don't have e-cigarettes at all. Raising the minimum legal age from 18 to 21. They did this while we were doing the project. So that's a change that did happen. Having a smoke-free generation. So no one born after year 2000 ever allowed to smoke cigarettes. Which is a very interesting policy because every government that proposes it gets voted out of power almost immediately after. Malaysia tried, got voted out. New Zealand tried, get voted out. England tried, get voted out. Then two forms of tax writings, I forget the details, but basically high tax or less high tax. Then some policies with e-cigarettes. So one where we just make any adult allowed to do it, or you have to be 25 or more, or you need to get a doctor prescription. So we tried different options for those. And then we tried to combine them. So I'm going to show you briefly the results to give you a sense of how the modeling results get presented. When we write a paper, we have all sorts of confidence intervals and lots of diagrams, make it very complicated. But when we present, we want to present to government simple best estimates, because that's what we found, that's what they care about. They don't want to see the uncertainty, they want to see your best guess. So we looked at using data from the US, from the UK, or from Japan, places where either e-cigarettes or heated tobacco products were in use already, to inform what it might look like if we were to legalize it in Singapore. I'll show you the American results here. They're quite similar for the others. Then we looked at the prevalence of any cigarette use on the top. So if I smoke, or I smoke and I vape, then I come in the top. Then we looked at any nicotine use. So if I smoke, or I smoke and I vape, or I vape but I don't smoke, that appears in the bottom. So they're the same now because the status quo doesn't have anything. Then we looked at what happens if we have a minimum legal age of 21. It should have an effect over 2 decades. What would happen if we have a smoke regeneration? Wow, big effect over a long period of time. What if we have tax rises? If we go very aggressive in our tax rises, we can have as big an effect as smoke regeneration. Younger people are more price sensitive, and that's built into the model. So a younger person doesn't have as much money, so they're more affected by the price elasticity that we impose here. How about e-cigarettes? So very little change to overall smoking rates using American data. UK data a little bit slower, but our best guess somewhere that it wouldn't change by too much. Overall nicotine use, you can see at the bottom, would be higher because it counts both people who are only vaping as well as people who smoke as well. Then we looked at having e-cigarettes on prescription. If you're going to have e-cigarettes, this would be the best way to do it, but it's not that great because you still get quite a lot of nicotine use. You can see at the bottom. Too fast. And we looked through various other things, like different combinations of policies, to try to work out what would get the best bang for your buck in terms of prevalence, disability adjusted life years, quality adjusted life years. So the implications from this were, so first, if you want to find out more about the work, you can scan the QR codes. If we are only looking at having a simple approach, simple policy, just one single thing, then smoke regeneration would be my choice. No one born after year 2000 ever allowed them to smoke or let anyone be. Having aggressive tax increases every couple of years, quite high percentage each time, would also have quite a big long-term effect. If you were to legalize e-cigarettes, then in the short term, it would have an impact potentially on smoking prevalence. But in the longer term, that would be reverting because you would have the gateway effect. So we see this in many countries. Young people start vaping and then they start smoking afterwards. And actually, that's quite a high percentage that go through the gateway of vaping to get through to smoking. So, two implications of this. The first was that we headed off this maneuver by big tobacco. So e-cigarettes are still illegal in Singapore. And I think that the government appreciates this now because we had this big issue of 1 or 2 years back when a lot of illegal vapes, because there's still some illegal vapes now, you can just get over the border from Malaysia, it's quite cheap. Some illegal vapes had anesthetics injected into the chemical. So people wandering around like zombies on the metro station, for example, right? Because of this. And that would have been potentially worse if e-cigarettes had not been widely used rather than limited use. We've also used this to justify some other policies. So for example, I got a call from one of my buddies in the health promotion board saying, hey, we just successfully raised taxes for the next year thanks to your modeling work. And we're working with MOH now on what are the steps we need to get smoking rates below 5%, which is the level at which you're not like an end game for tobacco control. So that's the first. We've had a genuine public health impact. The second, though, is we've also had an academic impact. I mean, the QR codes are to academic journal articles in pretty good journals. You know, Tobacco Control is the top tobacco control journal, as you would guess from the name. Lancet Western Pacific is not a bad journal at all. It's going to publish it. So I think that it's very possible to have both public health, practical impact, as well as an academic impact. You need to be like my colleagues mentioned. Okay, so I have a few lessons that I want to suggest. The first is, I think it's really important for academics to develop, like Ranshi, the relationship with policymakers, because you cannot wait until you need something and then go to them and say, hey, we need something. Because they're going to be like, who are you? As you saw from this, I help them, even though this is not my area. I've never done anything on tobacco control prior to this project. I did it because MOH was desperately needing help at that point. And so now it helps with my relationship. Now if I ask them for help, they'll help me also. Not guaranteed, but they may help me more. It's important to involve policymakers throughout. Do not wait until you finish your research and then hope that the research will be useful for policy. It's only going to be useful from the very beginning. You've already engaged them. And so where possible, you should co-design the research with the policymakers. As I showed just there, I think that you can get a win-win relationship. If you're solving real public health problems using innovative approaches, which is what you usually need to solve these problems, because if they can do it, something simple, they can do it themselves. They come to you for more complex stuff. Then I think it's very easy to publish. I think it's important that we try to translate the outputs into something that they will understand easily, because they've got so many things going on in their minds at any time. And also academic research is only one part of the overall decision-making process. And for heads of departments and for deans, we need to make sure that we have the processes in place that we actually reward faculty members and students when they work on policy relevant research. For the most part in NUS, that's not the case. Most of our faculties don't really care much about policy relevant research. They say they do, but they don't know how to count it. And so it ends up that what we can count is what counts. We can count papers, okay, that's what counts now. But actually, the real important stuff is stuff which is harder to count. So we need to think very carefully about how we motivate faculty members to do this. So for us, we make this part of annual appraisal, part of your promotion case, is like when I got promoted to co-prop, there was a letter from senior people in MOH saying, oh, Alex helped a lot with COVID, with smoking and all that. And that was part of the case for me getting my promotion. So we need to make sure we actually do have those processes in place. Okay, so thank you very much for your attention. I look forward to getting questions later on. But I think first we got another wonderful presentation to come. Thank you.
Thank you, Prof. Alex. It's very, very interesting and very insightful presentations. So we know that sometimes academicians and also policymakers, they don't speak the same language. So that's why the Guangxi, is it correct? But we need to work reciprocal, helping each other, and when they need us in emergency, and we can also stand up to help them. And also we have seen how the model itself can provide some projections where different policy may have impact on the smoking problem itself. So the government or the policymaker can make the best decision that fits, especially for the Singapore case. And for the next speaker, it's a little bit more from the Indonesian context, because we will have Assistant Professor Swamya Misra. He will be talking about dengue Indonesia, refining noisy data into targeted actions. Assistant Professor Swamya Misra, he's the expert of the infectious disease modeling and advanced statistic method for public health. He also expert in the Bayesian modeling, disease transmission dynamics, stochastic process, AI and also deep learning, and as well as the spread of health information through online and social media platforms. So Dr. Swamil, time is yours for about 30 minutes. And we have the question later. You can write down your question, and those in online, you can ask question and we'll read the questions. You can ask in Bahasa or also in English. We can help translate for the Bahasa one.
Okay, hi. First of all, thanks for having me. And okay, so I'm Swapnil. I'm an assistant professor. Alex is my boss. Used to be my boss, but he's a friend, more of a friend. So what I'll do today is I talk about our study that we have done in trying to understand what's the situation of dengue in Indonesia, and I'll take what Alex has shown a bit further, trying to say that how you can actually still do good research or research that you think is more publishable, but actually do something that's important and it answers a question that's required. Uh, you will see face of my colleague, my collaborator, my friend later, Andra, who probably should be given all credit, right? So everything that I say wrong is mine, but everything good that you see here is his, right? So. Let's get started. So what's the problem or what's the dilemma, right? So the dilemma is that in Indonesia, basically dengue is rising. It's essentially everywhere. 2024 was one of the biggest outbreaks that in Indonesia saw, but none of that necessarily means anything because we just have a system where not everything is equal. So for example, if you look at Bali or Java, they end up reporting cases with different age bands. So you have got full 9 age bands that people who will do dengue modeling here, they would be very happy. They will be like, yes, that's the data that we need. But then you have got places where basically you just see the number, right? So you see a number that says there were 20 cases. Now, the problem with that is that dengue is a very sort of interesting disease that the first infection that you see for dengue most of the time does not causes any harm. It's actually the second infection that's more serious for you. And because your second infection is more serious, that's the infection that's most of the time gets more infection, right? And if you go through any surveillance system or anything, essentially surveillance system works mostly on saying that somebody will end up being at hospital, then we will say that they have got a case or they will see a doctor. So that's one problem. And because your first infection and second infection, and then you have got different dengue has got different serotypes. So understanding dengue immunity and how dengue is evolving is quite important. And that's why age bands are required. But once you don't have those age bands, how do you understand anything? And then we have the other problem, which is like all of us want to stop dengue. Probably in current world, apart from many other things that people have been trying to stop dengue, two things that people want is can we run Wolbachia trial? So that's like trying to say how do we sort of catch the vector or how do we attack the vector? So it's not about giving anything to humans, but trying to say can we just take away the mosquito that's causing the disease, right? Somehow make that happen, or you end up doing vaccinations. Now, both of those are quite costly things. It's not that cheap, right? Like so, if you feel like if you want to do it, obviously, if it was cheap, it would have been given to us, right? It's not that government doesn't want to help us or and system doesn't want to. System wants to, but there is only limited amount of money, and that money needs to be well spent. Which means if it needs to be well spent, you need to know where you have to spend it, so that you get best buck for the where you get the best return for the buck that you're spending, right? Now, that's essentially what the problem we are trying to solve, right? So when we saw this work, so the backstory is that Andra is from Indonesia. So Andra always wanted to solve this, and when we solved this, so me and Andra sat down together and we discussed, and we were like, okay, we can solve, but then we asked the question. More important question is what to solve, right? We can come up with as Alex said, as academics, it's very easy to fool yourself to come up with a question that only you care about. And if once only you care about it, there is no profit. So we started our exercise of saying, okay, let's go and talk to MOH Indonesia or Arbovirus Control Program in Indonesia that what they need, right? What was one thing that if we would have given it to them, they would have been happy, right? And then so something that came out from there was 2 or 3 things, right? One is like they were like, we have got this different ways of reporting things. We have reported things in different bands, as I said. Like Java by itself reports 9 8 bands, Bali reports, but other places don't. So they are like, we want to do it, but we might not be able to do it. So up till where? Not 8 9 8 bands. Can we go for 4 8 bands? So what else we need to do? Otherwise, we want to come up with deciding where Wolbachia should happen, where vaccination should happen. WHO actually has got its criteria defined very well. So can you help us to get to that? We were like, okay, those are good enough questions. Let's try to see to solve them. And then obviously because Andra is an academic, he's a young researcher, so publishing and getting papers also matters to him, right? So then we were like, okay, let's try to see what we can do here that can solve this question. Okay, so essentially that's what I was trying to say. So what we want to do is essentially get 3 answers, which is how intense is the transmission. So it's, as I said, it's not just about numbers, right? As we all know, at times it's literally you have got a place that has got bigger hospitals, that has got a better health system. So you just get big numbers because that's a better system. Not necessarily that's where most of the burden is, or not necessarily that's where most of the disease is going. And then the second question that you need to answer is who, once you have answered that, how much is your transmission at different places, then can we decide what's the place where we go and target our vaccination. And then there is a third question that's like not necessarily directly linked to that, but that question is trying to say, is there a way that we can try to anticipate when we will have the waves, or how early can we understand that in Indonesia the transmission is going to increase? It's going to be a year when we're going to be seeing more waves, or we're going to be seeing more cases. So those were the 3 questions, and we sat down and we said, actually, if you go through the principle of statistics, all this could be answered. We can come up with a statistical model that can allow us to answer those 3 questions, and that's what we went through. So I'll try to go a bit more details into what we did and how each individually of those steps got answered. Right. So I would say more or less this is what finally is and as things look like. So what you see on the left is basically the raw incidence. So the raw incidence sort of gives you an understanding of which are the places in Indonesia that sort of might, and if you just look at the raw incidence, you might feel like these are the places which you have got the highest burden of, right? So I think all of you can sort of see which are those places they are. But then once you try to estimate those things back from seeing that those places don't necessarily align with the places where most of the force of infection is or where the real burden is. That's the final output of our method, right? So that's the change. The change is trying to say that if you would have just looked at the so if you would have just looked at those hotspots, you would have said this is where we should be looking at, this is where we should be looking at. But you can actually see that actually no. Okay, those places have some transmission or high transmission, but equally there are enough places which have as high transmission. And to be fair, there are places which in here end up being quite high. They're not necessarily that high in terms of the real force of infection, right? So this is the final output, but how do you get there, right? That's the question. But that's what you try to get, and that's what we went around, right? So we first said, okay, let's try to come up with a method. So the method that we took was that we will take age stratified data. So that's like data that tells you for each age band how many number of cases you had everywhere. Now there's this thing, something that's called Bayesian hierarchical model, right? And what I call as partial pooling. What's that? So the problem here is, as I said, not every place has got this age stratified data. Only few places have, and few places don't have. Now, the classical way would have been, okay, for the places where we have age stratified data, let's go and build something for that. But for the places we don't have, we don't know what to do. We said, let's not do that. It's not a problem that's not unsolved, right? Like actually, if you go and talk to people in political science or social science, that's a problem they have been dealing a long while, and even people in infectious diseases end up doing it. So what you do is very simple thing. Wherever the information is, we'll take information from there. For the other places where information is a little bit less, we'll try to see which is the nearest place to that. We will take some information there, combine that information and say, okay, these two places will have something similar, right? So in a way, you can always say, if you have to think it geographically, you can say like, okay, if you are looking at two neighboring places, they should not necessarily have very different sort of burden that they have. They should have the same burden. But the places which are different by, they should have different burdens. So what partial pooling allows you to do is places that do not have that much data, it allows you to borrow information from places that have data. So it's not just solving the problem of that we can model something together, but it's also solving this problem that not necessarily everybody needs to do a high surveillance. And to be fair, right, if you really go and talk to people who are doing the surveillance program on the ground, it's not that they don't want to collect this data, right? But the burden that's there on those people, like on those healthcare workers, the burden that they have, amount of people they have to look at, they just don't have that much time, right? If they had time, they would be very happily right that I got a person, I got a person today who was age 25 and they had dengue. The second person was age 80, female dengue, age 70, male dengue. But it's just that they don't have. So what they end up doing is they end up just tabulating total number of dengue cases they have. So now if you have to do that, you will either have to create more people or you have to overburden. None of that really helps. So that's what essentially what our model allows it to do. So it basically allows you to say, we'll borrow information and go further. But it just does not does that. It also gives you two things. One is the true force of infection. So that's what we really want to know. So that was the right thing that we had, which was the map that we had on the right. But apart from that, there is this thing that talks about the local reporting rate that I was trying to say that different places can have different reporting rates. So there are places which is just because it's a better health system, they will report more. And there are places which is not a better health system, they will report less. Because you have that, what ends up happening is that if you don't account for that, you will just see a high number and you will just see that it's a high number because they have more cases rather than thinking it's through the process. That is just that they are capturing most of the people that are coming. So once we had that, we just tried to see that, okay, let's see how things are looking. And we try to map that data and we just try to work on the case data, try to see whether it makes sense or not. Now, what you see in black here is sero surveys. So sero surveys are this specific thing which people in epidemiology who are here, they would say that's the ground. Right? Cases are something that comes from the essentially a health system, but sero surveys, if done properly, it basically is the ground truth of the in reality. It just does not tell you who is infected now. It also lets you know who might have been infected earlier, and that's what you really wanted to do. So what we were able to see is that actually just by using case data, which is surveillance data, we were able to figure out this seroprevalence data of 2014 quite well, and those fits were decent enough. You do see two different lines in here. One is the blue line and one is the golden line, I will say, right? So those are two different works. So one is the hierarchical model that I'm talking about. The other is a non-hierarchical model. As I said, the difference between those two models is just that in a hierarchical model, we are pulling information from everywhere. From a non-hierarchical model, you basically fit everything individually. Now, this does tell you that those two lines are looking equal. Why would you even do something else? So I think that's a bit of a nuisance. In a way, in here, you actually had places where we had everything and we had great data, so everything's good. For the places where you didn't have data, actually the hierarchical model ended up working. But story didn't stop there actually. When we tried to look at, there was one problem that we did have. So as I said, in a hierarchical model, you end up pooling information, right? So that ends up saying, if you're, let's say if you're trying to do something in Indonesia, what you will say is, we will say all the districts which are in one region, they will have similar things. And different districts will have different things, which means all districts in Java will have something similar, all districts in Central Java will have something similar, all districts in Bali will have something similar, and so forth. We did that, but we realized even at that time that also becomes weird because we had this island called Thousand Islands, right? So Thousand Islands, although it's part of the Java, but it's not necessarily, if I'm correct, I think it's part of Java. Yes, it's part of Java, but Thousand Island should not be near to Java. Anybody who is Indonesian and Android, he was like, it does not make sense of me, right? This all thing is in a one island. Thousand Island is somewhere outside. We are saying these two places have got same kind of structure, just cannot make sense. So at times actually non-hierarchical model also is useful. So or what I wanted to say was hierarchical model every time just by using common sense does not work. You have to go and talk to local people because they understand what's problem in here and then. But for everything else, actually hierarchical model ended up working. But I just wanted to say that there is this problem in hierarchical model where you have to think at times. By not problem, I would say it is how a modeler should think every time that why am I pooling? Who all I'm trying to say to be equal? It works, but Thousand is just somewhere outside and it does not. So that happened. But as I said, finally what you see is that so it's one of the other transmissions of the what I had earlier is what you see is that although Jakarta ends up having lot many cases, but it actually has a lower FOI because it has got a higher reporting rate. That's what our model got out. And West Java actually have got a higher FOI, which is the real thing, but basically they have a lower reporting rate, and that's the thing. Okay, so now, as I said, once you have had all this, what we wanted to know was that how do you do the final step, which is like which are the districts where we should be asking people to vaccinate without really asking too many people to go and do zero surveys, because as I said, zero survey is the ground truth, but running a zero survey is very expensive and it's not usual also, right? Like if you look in the history of Indonesia, we have not had more than 3 or 4 zero surveys. Those have been done only in very small places, but all districts basically have their health, like sort of health surveillance data that comes in for cases. So then we wanted to answer the question that how can we go and now expand it for everybody? And the problem was that we wanted to think was we don't want to do the same mistake that we did earlier, which was that you club Thousand Islands same two places in Java equally. So we said then rather than thinking that everybody in the same region is same, we also have to go a level up and say what kind of things can be same for people. And for that we said, okay, the disease is not just defined by where you are, it's also defined by other factors. And those other factors are things like you have got environmental covariates, then you have got things like mobility, and then obviously geography. So we basically fine-tuned our model and came up with a final model which combines all of those things together to say now we just do not say two things are equal just because they are nearby. We also say things are equal because they might share the same environmental or sort of same climate factors. This then allows you to understand that okay, yeah, Java has a bit of a different climate than Thousand Island. Its geography is different, environmental factors are different. So that will allow Thousand Island to have much different estimates than whole of Java, and then combine all of those things together. So then what happened was, if we again didn't use zero survey data and I will end up just running our models, we realized that our models were just too overconfident if you just look at for few estimates. But only when you started giving it the zero survey data, which at times exists for few places, you really ended up getting sort of right uncertainty, and which is quite important, right? Because in here you could have got sort of, you could have become overconfident and uncalibrated, that would have helped you that much. So finally, we came up with this exercise where we said, okay, what we really need is sort of a plan where we have to say which are the places which have got sort of, which now under our model is giving places which will have vaccination strategies. So what we realized was if you just looked at the raw incidence and if you looked at the FOI estimates, only sort of, I think only 6 or 9 of, or yes, so only 6 of the 26 districts were common in both models. Everything else essentially was that incidence model, which just accounted for the places that had basically high incidence. It basically misclassified a lot of people, and true burden was missed by the high incidence. So which means those are the places in the top that we were always missing. And then the sort of low burden model, also there were false alarms because you just had high reporting. So we ended up missing a lot. So this combined framework sort of gave us right idea about that if we can get the right FOI for people, we would be able to do, and that's why this work is important, right? In a way to say, if you would have just looked at the raw numbers, that's not useful. Now, so yeah, so that's the same diagram as essentially being shown in a different way. So once we had that, we went to our last question, which was about that: is there a way for us to somehow think about how dengue goes through the island of like the not the island of Indonesia, but all archipelages or all different 17,000 islands of Indonesia. So what we did was we first tried to see whether there is a uniformly something. So what we found was, although this diagram says it almost is uniform, but it was not necessarily as uniform. We tried to see, is there a signal that can say people to say that dengue is coming? That's all what we wanted to say. It's not really a prediction of saying I will predict what will happen next year, but I'm just trying to say, can we look at something in Indonesia to say something will happen? And if you will follow my hand, the geography I'm trying to say is, because that's the final result, was almost like dengue in Indonesia moves from west to east most of the time, which means there is no relation as such between them, but climate and everything makes it happen in a way that if you end up seeing something goes up here, you might not be able to help people here, but it's a good enough indication for you to say that it is truly start going to the right. So in a way, it ends up being a good way of looking at things. So in a way, you can, looking through a surveillance structure, you can think it this way. Try to have a surveillance in this part. If these parts end up seeing a rise, we might miss predicting what's going to be here. But as soon as you end up seeing things going rise here, you should be ready now that it will go over. And this lag is not like a day or a two or a week. This lag at times is 3 weeks, 4 weeks. So you actually have some time to plan. So it's not almost, at times this lag can also be 3 months or 2 months. So which gives public health people enough, because if this lag would have been 2 days, it's a useless thing, right? That something comes here and if it goes, probably it will take 2 days for information to be passed from here to here, right? So that's not what you wanted. What you really wanted was whether that lag is meaningful or not. So in order to do that, again, I think if you have to take up a story, I think there are too many things that we tried, but what I wanted to say in general was, if you look through only one model or one way of characterizing anything, we couldn't get anything, right? It's only when we try to look at many different things, all different methodologies being tried, trapped together. And to be fair, it's not that we are trying to look for anything. We were happy if we wouldn't have found any signal and just said to people that there is no signal, we should stop, right? But what we didn't wanted to do was the fact that let's not just stop at trying simple things. Just because simple thing didn't work, that doesn't mean that there is no signal. At times you have to go and innovate and try to do more things and be a bit more pragmatic around it. So essentially what we realized was, if I go back actually, is to say the signal by itself might not be fully. So in a way, there is some discrepancy. This area ends up getting things higher than this area, or even within here at times you get higher incidence here later than higher incidence here. But overall, if you divide it into 4 or 5 parts of in Indonesia, that signal is constant, right? So individually, if you would look at places, they might not have a constant signal, but those things being seen as big regions by itself, actually you end up seeing those signals. And also, what a lot of these models ended up helping us was like, which is a backstory, is like these were also the things that we finally seeded back to my vision hierarchical model that I said, where I wanted to have the right kind of climate and environmental factors. So only the factors that helped here that helped us. So essentially, what we got was that yes, there was a longitude, like in a way, there was some correlation between the longitude and the phase lag that you had, and there was some signal from sort of west to east, right? And but more importantly, what we also found was El Nino actually has a very strong effect in Indonesia also, in a way that every time you had an El Nino, what preceded after it was almost like something that was twice or 4 times, like it was twice the incidence that happened the next time. So in a way, the only way you could have thought about that you will end up seeing something very big was actually El Nino. Sort of, it didn't change the seasonality, but what it really changed was how high a peak is going to be. So things happened at the same time that they're supposed to happen, but it's just that they would get their sizes increased. Okay, so I think I'll skip that because that's too much. But then what I basically wanted to say was, finally we came up with this thing, and that's what we wanted to talk to, and that's what we are right now trying to talk to MOH, trying to see how are we really gonna be deploying things, right? And what you should be doing. So what we sort of see is what's plausible at times is finding the places where you might be able to deploy vaccines because you can get a better understanding of FOIs at age level 9, which is the WHO standard. There are places where weather warnings, and there are things for which weather warnings will end up quite good and they might be useful. But then for few things, what's sort of still unpredictable is how are we going to think about the year-round vector control, because those things are quite still changing and you really don't have quite, at least up till now, whatever we have got, we have not gotten a decent signal that we could come up with a year-round strategy, right? So what you have is essentially a warning system. You don't necessarily have a system that's looking throughout the year and giving. So it's almost like an alarm that goes off, right? So it's like, it's not a prevention system. So you can think it as a fire alarm, right? That it's not that it will stop the fire, but if it sees fire, it will blow off, right? So, and as I said, there is one problem which is there, obviously, is that it does not stop. So there are few places where we'll have to take the hit of saying that they will not stop anything there. Those places are just the places where we are looking for signal. Okay, so at the end of it, right, you have to still think about what's the useful of this whole framework, right? So this framework has been done for dengue, but what we really think is there's nothing specific to dengue in there. In a way, you can take the model and try to look at other diseases, so which would be Zika, chikungunya, or any other disease in the same family. In a way, there are things specific to in Indonesia in there, but then again, if we end up working with people or we end up giving models to people in other countries, they can go around and adapt it to the geography. So, for example, people in Vietnam can probably take this and see whether it's gonna be helpful for them or not. And I think a lot of that's happening because Android did a lot of work by making sure that everything that he's doing is right now open source and people can use it and it's there. And from the day, right. So, in a way, what I wanted to say was a lot of this, if I would have just taken my approach of academic eye, then nothing would have happened. In a way, what I would have gotten is probably a good model, but not necessarily anything much, because I would have just come up with a model. I would have said, I have got this hierarchical model up and working. It produces good estimates, but I wouldn't have been addressing the problems that people wanted to answer. And the way those problems got answered was actually talking to the arbovirus control program on a on a weekly basis. And by weekly, I mean it's not me talking actually, and talking to people on a weekly basis. So I think that's quite important in a way for people to think about. If you just want this, I think you can live your life very happily by not talking to anybody. But then, as Alex said, that would just mean you will end up being in a paper. And ideally, what you have is, if you end up, so I actually feel it this way, because we were modelers and we were talking to somebody in here, that allowed us also to have impact on the other two quadrants. Else, it's actually very difficult to have impact on direct numbers. Like, why would somebody try to hear someone like me or Andra? Why would a funder or WHO look at me? Because once they have Ministry of Health who actually has most of this stuff, so I cannot have a direct impact here. Communities, no way my academic work tells me that I can go to communities and tell them and what's happening and think about them. But actually, by addressing what the Ministry of Health has in program, make it in a way that this really goes to people who will get benefit. Allow me to say that actually it's not just that we are helping Ministry of Health, but in a way directly by helping them to program where it's for, we are also helping communities. So I think that's the thing I wanted to stress in a way again, that if you want to be a modeler, you can be a modeler by yourself. But if you want to be a public health modeler, you have to talk to people and you have to do policy relevant work. And policy relevant work has nothing, like there's nothing big about it apart from just being more pragmatic and having an open heart and an open mind and saying that people know more than us. and by people I mean actually Ministry of Health. And I think as academics said, as Alex said, as academics, there are two things that I feel. One is we tell a lot of lies. Other is also we have got an inflated ego. So those are two things. If you take those two things out, because somehow we feel we are the most intelligent people around, we know everything, we can solve everything. Technically, we have nothing apart from a funding doing research. So if you really want to solve things and you want to solve things, the way is to go around and talk to policymakers or talk to people to whom really things matter. And policymaker does not understand your language. That means you have to go and make them understand. So in here, a lot of Bayesian hierarchical modeling was not something that somebody in Ministry of Health was understanding, right? But what they did understand was, oh yeah, we understand that Java and Bali has got better surveillance system. So they agreed with that. That yes, we do understand that at those places the health systems are better. So they were happy to agree that there might be other places where there might be more cases, but we are not catching them. Right? So if you talk to them and you talk to the language that they understand, you can actually pass a lot of things to them. Okay, so I think finally Andra is here. So thanks to him because all the good work has been done by him. But then apart from Andra, there are various other people. So Hannah had an Alex is here from NUS who I would like to say thank to. Then we have Iqbal from Indonesia who helped us a lot. And then we have Samir Bhatt who helped us. And then finally, I think most of the biggest help goes to the Arbor Control Program and the Indonesian Ministry of Health. If you're more interested in any of the work that's in there, those are like, as I said in the academic side, those are the QR codes. Thank you.
Thank you very much, Dr. Somil. I think it's very relevant to Indonesia context. We often face incomplete data from surveillance, and based on the explanation that if we rely on the raw data on the incident, it might be misleading because like the high reporting cases might not reflect the high force of infection. So that's the thing that we need to also consider when we do the disease modeling and thinking about the intervention for public health. And now I think it's time for questions. I would like to invite the audience for any questions. We have the audience here offline, also the audience from the Zoom call. So maybe perhaps we start from the in-person audience. Anyone have burning questions? Yes, please. Please mention your name and also who your question addressed to. Thank you.
Hello everyone, my name is Faiz Mahfuz from the Institute of Tropical Medicine Antwerp. I have two questions, one for Professor Alex and one for Professor Shafir. Okay, for the first one, is sometimes when we want to involve government agencies, we need to align with their agendas, right? And when the head of agencies changes, or the people or the PIC that we are talked to or planned with the project is actually got moved to other departments or other regions. Sometimes it happens a lot in Indonesia. In Guangxi context, should we academics follow their agendas when the head of department changes? Or when the PIC got moved, what should we do to, let's say, anticipate it or to the next thing? And for Dr. Shapnil, there's a interesting part of your presentation is that when you mentioned when we borrow neighboring data, I would like to ask, do you consider their similarities? And it actually got answered on the next slide that, for example, geographical features that you incorporated the environmental criteria. And I have a question. If in Indonesia we are inside the ring of fire and also we have a lot of natural disasters, do we also consider that as variables to model for the prediction? Thank you.
I think that's two questions. The first one is about the turnover in the government. We already engage with them, and then the people change. Maybe you have some suggestions.
Okay, so it's a very good question. it's not a purely Indonesia thing. Our government also has changes from time to time, and then if your relationship is solely one-to-one, then you're at serious risk that you invest in a relationship which is not going to help you later on. So I think that it's important that we try to go for a mix of two things. One is to have a lot of those one-to-one relationships. And it cannot only be institution to institution, because you do need to, like, you go for makan with each other and you build up the relationship that way. I think that can be stronger than if it's a purely institution to institution relationship. But it is still important to have institution to institution relationships. So you want to try to get both of these different pathways. If if you think about what are ways that you could make the institution to institution work, things like what we do is we have an annual meeting, I mentioned, with our permanent secretary and a DGH, right? And that is a way that we are getting the kind of the continued support from the leadership of the Ministry of Health to our school. We also have regular 6-monthly meetings with the leaders of our communicable disease agency, with our health promotion board, and so on. And that again is to try to keep those, create a foundation for more of the relationships from our schools to them. But what I find is that because the government always restructures, it can be quite difficult to keep track of who's responsible for what, because a new department gets formed, someone moves from one department to another department, same in Singapore and Indonesia, I guess. And so keeping that, okay, we'll have these regular meetings means that our people show up, their people show up, and if we find out, oh, someone is new or someone's gone, then you can start to build that relationship, you catch their WhatsApp number and so on. Yeah, so I think that's the approach I would try to take.
So before answering my question, I'll just clarify one thing. I don't think Alex or even I was trying to say that you have to align with the agenda of the government, right? You have to align with the question that's being asked, right? So you have to ask them the right question, right? You don't need to align with an agenda, right? Because the word agenda by itself could land in different places, right? So as a scientist, one of your thing is not to align with an agenda, right? So what you're supposed to find is, I'm not aligning with an agenda. What's the scientific question they want to answer? And this is the science that I can provide, right? So nobody is asking you to go and say that if there is a new government and they have an agenda of saying that we do X, then you're supposed to provide evidence for X, right? That's not how science should be done, right? So, and that's not what's being even said, right? What we are trying to say is, even if somebody's, in fact, I'll put it the other way, even if somebody is doing that, you can still do a good job of asking them what's the scientific question they want to answer, and you tackle that scientific question. You don't tackle the agenda. Okay, so now the easier answer, because that was from my part, right? So have we tried natural disasters and other things in the model? No, we have not, right? A reason for that was we wanted to have something which is not necessarily answering just Indonesia as a single thing. It's trying to answer it for each different districts throughout. So that data didn't exist, right? So in model, how do you account for that is basically having an extra term or a noise term, which technically is for everything extra, right? So in a technical way, the way to do is you take all covariates, you put a dummy covariate, or like which you say, which has a temporal effect or a spatial effect, and that's basically your noise term. And you then say, what's the relationship between my noise term and what I'm saying? If it ends up becoming good, then you actually, that's a signal for you to say that all the things that I have tried, there's something more in there. If noise is explaining a lot of things that's happening. But if noise is not explaining a lot of things that's happening, then you're like, I would have missed few things, but I have accounted for most of the things. Hopefully it answers both parts, whether we have done something and how do you know that if you don't have it, whether it's important.
Thank you very much, and very good presentation. Thank you, and also the opportunity to ask.
Thank you. Maybe we move a bit to the person in the online, and then we'll go back to the offline later on. So the first question is from Agung Anugrah. What may be the ideal characteristic of data that can be analyzed using Bayesian hierarchy model? For example, sample size, variance characteristic. This Bayesian always requires multidimensional data, such as climate, disease incidence, and geographic. Any of you wants to address the question?
Okay, I will. So there's a very simple answer, which is like the beauty of Bayesian modeling is that you can work with whatever, right? So it does not actually, so in a way, if you don't do Bayesian work and if you would have been in a frequent test work, there is a lot of question that talks about what's the sample size, what's this, what's if things are different. Bayesian modeling allows you a sort of a principled framework to answer all those questions by incorporating what people say is priors, which is correct. I call that as domain knowledge, at least in ID modeling. So rather than thinking of priors in Bayesian modeling as something that is statistical, you should actually think it as, okay, how can I help my model? And how do you help your model is by thinking like an epidemiologist, talking to people to understand. If I didn't have data, what would we have thought is happening here? Or what's the base rate here, right? And there are a lot of those things can be got up. So Bayesian modeling allows you that. So that's the answer, and I'll try to answer because those 2-3 things are similar here, which is like how do you take age stratified and non-age stratified data together? It will be a bit too big to answer right now, but I would say among the papers, the last paper that I have, which is on medRxiv, actually exactly does that, where it takes data from 9 age bands, 4 age bands, 0 age bands, different years, and all those things together. Again, the same answer is the Bayesian model allows you to sort of combine all of those together.
So only to add that I think the first question, I think is kind of fundamentally posited on something wrong. Bayesian does not require multidimensional data. It allows you to use multidimensional data. It allows you to bring together all sorts of different data streams that would be difficult to do in the normal statistics that you will have learned as part of your MPH or maybe your PhD.
And the next question is, I think you haven't mentioned about this before, but I think if you have any additional information, because you said that to Prof. Alex, consists not very interesting to have a good cooperation. So how do we as academia position ourselves in the face of the government's goal or intentions, as they might not be say scientifically interested, publishable, neither align with our research directions or ideals?
Okay, so I think there's three parts to that. There's one is it always going to be publishable? No, it's not necessarily always going to be publishable. And so within our school, our approach for this is that we put value on non-publishable work as well. If we don't do that, then no faculty will want to touch something that cannot be published. Right? So I mentioned before, we have annual appraisals. In our annual appraisal, we looked at how good was our research, we looked at how good was our practice. We also hire professors on the practice track. Their fundamental mission is to do useful work. If they don't publish a paper, that's fine for them and for us. For a tenure track person, they need to publish papers. But for someone on practice track, it's not necessary. And that means then that we can take on some projects that we know are not likely going to get ever published, but it's okay because we will value it and someone will be there to do it. That's one of the parts of the question. Now, what if it's not aligned with our research direction or our ideals? So I like to think that in public health, our people are very applied. We actually care about solving real problems. It can be quite different in many other parts of the university, where theoretical work is seen as being more difficult and more interesting than applied work. But that's not the case for us. We're fundamentally all from different disciplines. We're using our disciplines, applying it towards health. That's what we do. So I think that very often we want to be doing this kind of applied work, even if it's not like our core area. But I would caution that that's only really going to be the case, or it should only be done by people who have security already. So I have tenure already, meaning that NUS very difficult to get rid of me. But Sprockville is not yet tenured, so in 4 years' time, we can kick him out, right? And so if he were to take on the smoking project that I spoke about, that's very different from his real research. And so will it count for his tenure? We're going to send over his tenure dossier to professors at Harvard or in Oxford or whatever and ask them, hey, what do you think? They're going to say, oh, I don't understand why he got smoking in there. So that can be harmful. And so what we will try to do then is to get the more kind of offbeat stuff, which is not from someone's core area, and make sure that's either done by someone who's got the security of tenure or who's on the practice track. Therefore, don't need to worry about getting judged by people from Harvard and Oxford. Then the third point that I wanted to say is, and it relates to what Swapnil said before, that well, I mean, we are still scientists, so I'm not there to just push an agenda that the government has. Like if MOH had come to me and said, we really want to legalize e-cigarettes, please do a critique of the model, I would have done that because I'm just doing science. If they said, please now develop a model that shows e-cigarettes are good, I did the model that shows it's not good. Right? I'm not going to change the model to make it seem like it's good all of a sudden. I think it is still important that we maintain that kind of that we continue to do the right thing and our integrity.
Okay, thank you very much. Yeah, that's how to balance what the government needs, and also we try to provide as much as we can, but especially for those who are distant also, it might be easier to accommodate their needs. And maybe before the next question, I would like to also invite people from that come here that might have questions, maybe. Anyone has any questions? What else? Okay.
Because you asked.
Yes. I need to be someone.
To Alex, I think. You mentioned about having collaboration with the policymakers particularly. I mean, you've been doing this for years, but especially this is the young generation. What will be the tips for them to initiate this collaboration or communication with the policymakers?
So it is a good question. When I first moved to Singapore, I did not have any of those connections. And so someone more senior helped to introduce me to the right people. And then I started working on the relationships. So for the junior researchers, so I hope that there are senior people like Donnie at the event who are able to help to start to connect you up. You need to go part by part. You can't like just walk into MOH and say, hey, I want you all to be my friend. So I think that's one. If you are doing your PhD or your MPH, and you're maybe more research minded and you want to go down an academic route, then do look out for the people who are doing your MPH or maybe doing a PhD, but are more government minded. So I found that some of my students who have done more of the policy related work, they really benefited by becoming friends of the MPH students from MOH. And then later on, they can call in the friendships. Yeah, so I think that's the other one.
I'll just add. So one thing I also feel is what young people should remember is talking to a policymaker is very different, right? So somehow I feel a lot of young people feel like I'll go to a policymaker and say, I have this 5 papers, I have this 10 papers, that's my, and like that's the, somehow come up with a metric saying, this is my index or this is my citation. None of that will work with the policymaker, right? So don't do that. In fact, that puts you off. As soon as you do that, you will be out of the room, right? Even if you are one of those people who might have gotten probably, let's say, 5 best, bigger impact papers that talk about, right? So important thing is to go with the humility and to understand that what they want and talk to their terms, right? Again, as it's coming again and again, they don't care about the paper that you have got, right? Even if you have to talk about your paper, you should talk about what was the impact of your paper, what it helped to solve. And it's actually fine even if it helped to solve something that was not policy relevant. But if you pitch it, like ideally, the best thing to talk is if you tell them what was the policy relevant question you helped to solve. But even if there was some scientific thing which still aligns with them, trying to tell them what you helped to solve is much better than trying to tell them that you have a paper at X place and number of X papers.
Any more question? I have a question actually. Oh, sorry. Oh, yeah. Oh, me? Okay. So, okay. I'm just wondering how you communicate to the policymaker about sometimes they'll have uncertainty, especially when you need urgent decision making. So, what you usually do for that case?
Okay, so that is a very good question. I guess there's a few forms of uncertainty, right? There's things like uncertainty, like statistical uncertainty, like we don't exactly know the parameters, we don't know how the rate is this high or that high. And so if all that I'm showing is, I think this is what's going to happen next, that's the only thing, then yes, you show the uncertainty of that. But typically what I find is that what they want to see is a comparison. What if we do this, what do we think will happen? If we do that, what do we think will happen? Like I showed with the tobacco control laws. And for this, showing the uncertainty just confuses them. Because there's too many lines on the screen. It's hard to visualize what's, if they're overlapping and so on. And so what I would tend to do there is hide the uncertainty and just verbally communicate. Bear in mind that we are uncertain about some of these estimates. What I found during COVID in particular was that the kinds of uncertainty that they most related to were scenarios. So for example, what is our best guess for what will happen? Versus what if it's really bad? Versus what if it's really good? So we worked out like, we think that here's our 3 scenarios. We explain what the scenarios mean, and we show those scenarios. So it's not really about the uncertainty attached to it, but rather than we don't know exactly which path we're going to go down. We'll show you the 3 paths. For some reason, so I'm a statistician. I always want to show confidence intervals and stuff.
Yes.
But actually, I find that that's not really the way that they were thinking. They wanted to see different kind of uncertainty.
So I think one more thing to add is almost related to the last point, which is as a modeler, as a statistician or a bigger person doing science, you end up doing too many uncertainties and too many things, right? Talking to modeler, talking to a policy maker, giving them uncertainty around the question that they ask actually is something they can digest. So that's almost like a scenario, right? So it's like they asked you, when will this happen or what will happen? You end up giving them uncertainty around my projection has this uncertainty, my model has it. That's too much, and that's when they get off. But if you tell them, whatever happens, what I can tell you for sure is we are increasing or we are decreasing. What I really don't know is your question is whether it happened in a month or a 2 months time. I believe it will happen somewhere from a month to 2 months time. They would actually understand that uncertainty because that's the question they want to answer. So it's the peripheral uncertainties that we want to communicate that should not be communicated to them.
I guess another thing about communication with the policymaker. Bear in mind that we are typically communicating with policymakers but not decision makers. So there will almost always be some kind of an interlocutor in between us and the person who makes the decision. And so what I found during COVID was that within our Ministry of Health, we have someone there who really understands modeling, right? We've worked together on many papers in the past, and that was invaluable because then I can give him my graphs and my slide decks, knowing that he will communicate well to the Prime Minister, the Minister of Health, right? That he will say, don't look at the number for the peak because it won't be exactly that number. I trust him to be able to say that to them, a bit higher, a bit lower, maybe a week later, a week earlier. So he's communicating that uncertainty. And that happens because we have built up that relationship already. And if I was just uploading to some anonymous person once a week, here's our latest forecast, and somehow trusting that they know how to present that, I would be feeling so anxious all the time. What if my results are being misinterpreted out there?
Dr. Chita, next question.
So I think this is for Fabio. You mentioned that this your own modeling with the national Indonesia data. It shows that the epidemic wave is coming from the west to the east one. And also you shown that because we have 5 main islands and one of it is in Kalimantan. And in Kalimantan we also have Kuching and also Brunei. Do you see this wave is also affected the Kuching and also it is just
So 2 caveats, right? So one is I think I'll say if we will end up looking at individually and regions from west to east, right, we might find at many places things end up breaking, right? So it's not necessarily just a linear line that we can go over, right? So that's more or less a very crude but still significant line, right? So that why I was trying to say is actually that island in between is very weird. By weird I mean its change are not necessary. So in a way you don't see it being in between the both waves. There are many interactions, and the problem is not the problem. I think the beauty or why it's not there is also because that region as a whole behaves very differently because of what's happening from the Malaysian side, what's happening from the Brunei side, and all those. But it also does have some signal, right? But what we are not sure is what's happening on the other side because that data was not there.
And I think that shows why it's really important for our region that we don't just solely think in countries, but we think of a regional approach. Because a problem in Singapore is a problem in Malaysia. A problem in Malaysia is a problem in Indonesia.
Anyone from the audience here? We go back to the online Zoom questions. The next question is in resource constrained setting, like many low and middle income country. So infectious disease modeling places greater emphasis on identifying where intervention will have the greatest marginal impact rather than simply where the disease burden is the highest.
That's a very good question. And it's also a difficult question, right? Because first of all, you have to define burden. What is burden, right? So if burden is just defined by raw incidence, I would be like, no. That's a clear no, just because we know that burden could, if it's raw incidence, then that burden is not necessarily the right indicator. But now if you say your burden metric is the force of infection, which is sort of the right indicator. Now the question is, how do you do that? The real answer is health economic model. Right? So you should not just stop at doing this. You should also do the next step of looking at the health economic modeling, trying to see at this place, because again, right, burden and numbers don't necessarily make sense at times because there are a number of people, how much it will cost. Like putting an intervention in Bali might cost you different from putting an intervention in Jakarta or in Jakarta, right? So it's not just the number of burden, it's also about the impact of the intervention, then cost of the intervention. Right. So if you have to really answer that question, then health economic assessment modeling is the right thing to do. Where transmission modeling will play a big role, because I think traditionally I feel it's not that people don't do health economic modeling. In fact, I think within the region we are better placed than most of the other parts of the world in terms of doing health economic modeling. But fusing transmission modeling or like this dynamical modeling and health economic modeling together is something that has not happened. So we still work with static estimates. So we have to work beyond those. That's how I.
Maybe just 2 points to add. So there's a kind of a recent wave in health economics around distributional cost effectiveness analysis. The idea of this is that you don't just solely try to optimize what is best at this whole of society level, but rather you try to reduce inequities. And so rather than just looking at the cost per year of life, you look at whether you're able to get a reduction between the people amongst whom the disease burden is highest relative to the other groups. And you may prefer that even if it is suboptimal when you think of society as a whole. That's the first. It's a really exciting area of health economics. It's worth exploring. The second is, so when I first started work, so I used to work on plant diseases before I moved to Singapore, and it turned out Singapore doesn't care about plant diseases, so I switched to human disease. And when I first started doing that, one of my senior advisors over at Duke and US Medical School, he gave me the advice. I was coming up with a model of wanting to show an optimal vaccine policy or something. And he was like, Alex, he didn't physically hit me, but verbally hit me. Alex, don't talk to a policymaker about an optimal policy, because policymaking takes into account so many different things. It's not just what your model says. There's like what the voters say, there's what the constraints are, there's what minister wants, there's all these different things. And your model or your research is just one part of that. So if you say that my model says that the best policy is that we should do the following, like we should intervene in a particular area, that's what my model says that's the best thing, then you're kind of taking away the right and the responsibility of the policymaker who's getting paid to make the decision. Because now, if they do something else, then you're implicitly saying to them that they're wrong. And that's not my place as a modeler to say that, because they're balancing so many other things that I'm not aware of. And so I feel like it's a good question, but also it's about something that is not the place for modelers or for researchers or academics to try to come up with a blanket statement. You should do this or you should do that. Because we need the government to do that, make the decision. they get paid more than we do, so they should make the decision.
Thank you. So we have two more questions. The next question is related to the El Nino patterns.
I probably so I'll have to go back and see. So I do remember probably the numbers before 2009 are not necessarily like the surveillance and the numbers don't necessarily match the current depth at which of current state of the thing. That's what I remember, but I'm not 100% sure. So if I can cross check that and then me trying to come up with an explanation might be good rather than me on spot giving an explanation.
But I can say Singapore had a big dengue outbreak in 2005, which was linked to El Nino.
So I think El Nino and dengue outbreaks being linked is more or less people understand that. But then, as I said, right, that work that we did is actually not on the force of infection, right? That work is on the reported cases, right? So that it depends a lot on if somehow you didn't have a better surveillance system at that point of time or those things. So a lot of those could be just those artifacts also, and that needs to be accounted for.
And the last questions is about many infectious is model methodologically sophisticated but difficult for policymakers to interpret. Is there any simple decision-making framework that policymaker can trust and also apply across different infectious diseases? This is a difficult question, I think.
No, it's an easy
Bobby.
question. I love this one. So, the last 3 years or so, I have been working as part of the Lancet Commission to improve the use of epidemiological modeling to inform outbreaks. I don't remember the exact name of the commission. But it effectively is formed to solve the question that he was asking about. So during COVID, models were used a lot. And that was for many people in the general population, the first time that they knew that mathematics could be useful for an outbreak. It also meant there was quite a bit of a backlash against modelers. So like modelers in the UK were getting salty, or like they had people waiting outside their house so you could take photographs of it, put it in newspapers, very shocking. So there's been a bit of a backlash against modeling because there was a conflation between policymakers having a difficult decision to make, and maybe an unpopular one, and saying, oh, but the models say that we need to do it. So the Lancet Commission was formed to try to make modeling like better for policymaking. And so over the last 3 years, we have met so many times, we've had so many long meetings, we've written so many words, and I'm hoping that this year, the end of the year, that the report will finally be accepted and published in the Lancet. And that lays out advice that we're giving for modelers how to do the modeling better, for policymakers to interpret and critique models better, and for the communication of modeling. So there's a few different strands to that big report, and I would recommend that you take a look for it because it should be very fun.
So can I just add something to Alex's was? So I think, first of all, I think as Alex said, the framework is coming out. But I think a lot of this backlash or a lot of these things also comes from the sort of fact that we want, which is coming back to Alex's point, which was why, as an academician, we try to just put too much into our work of saying we had an impact. Probably we should take away that line. I like the line of people saying, try to say we provided an evidence, right, rather than you having an impact, because I said policy making requires too many things. There are too many evidences that are required, and okay, may not be true in most parts of the world, but I still end up saying, not the policy maker, but the decision maker has also one more bigger counterfactual to account for, which is what's the decision that will get me the next election, right? So that's one, and then a lot of other evidences. So all of that get put into something. So first of all, if you try to distance yourself from that, and then you try to see why I was trying to give for that answer was, if you think your work as an evidence, not as a thing that will guide everything, it becomes very easy to actually even distill your complex model into a piece of evidence that you would do a lot of complicated stuff, but your evidence is very small, right? That says accounting for immunity, accounting for health structure, accounting for population structure of X place, we see that X gonna happen, or if you do X, Y gonna happen, right? That's your evidence. Everything else is not what a policymaker needs, but it's just because people try to conflate everything, they want to say a lot of things. And that's when your policymaker also gets sort of like, this is too much information for me to deal with.
So how to frame the information also very important to deal with the policymaker. Any more last question maybe from the audience?
Dr. Vika, I think in the online.
Oh, in the online,
one
okay.
is more.
One more question. I think that one is already made.
One new, wait.
Okay. In country like Indonesia, HIV is a concentrated epidemic with substantial geographic and key population heterogeneity. Beyond epidemiological factor, transmission is also shaped by social and structural determinants such as stigma, criminalizations, unequal access to service. While different modeling approaches have been used, it remains challenging to identify the approach that best informs policy. In your opinion, what modeling approach is best suited for setting like Indonesia? That's a long question.
It's a very complicated question. I'm sorry. So there are things that modeling struggles with. We have historically struggled to represent things like social disparities and heterogeneities in the population. That's one of the criticisms that the community received during COVID, was that, like in the UK, where I'm originally from, that most of the people doing modeling are usually European males, middle class. They're from a very specific strata in society, and so they're not frontline workers. They don't know what it's like to live paycheck to paycheck. And therefore, when the modelers are developing models of interventions, they're focusing on things that they know about because it relates to their experiences, and they may not be able to fully characterize some of the negative effects of those. For example, if you're not able to go to work, or let's say you have to go to work because you've got no money, then if our models are assuming that everyone follows the policy, but that's not going to happen in real life, then obviously the model's not representing what reality will be like. So I think that some things are easy to model. It is quite easy to model what if our PrEP uptake were higher, or what if we have more testing, we increase testing rates or something. It is very difficult for us to model what if we can reduce stigma. Yeah, stigma is very important in epidemiology determining, but like trying to represent that in the kind of causal pathway from stigma to effect is very, I don't know how to start building the model of that effect. And therefore, there are certainly, we shouldn't think that modeling can handle anything which is important. There's a subset of things which are important which we're able to deal with.
So I think I'll add it in a way to say, first of all, first thing is to answer that modeling is not everything, right? And to be fair, modeling is only a small part of public health, right? Like the other parts are equally important. Although being a modeler, you have to get your ego down to say that, but I think that's important. But the more important thing is, for that question, I feel it more or less says, if I look at from public health angle, what you need there is more epidemiological studies and more community-based studies. If you end up doing those two things, that will give you a handle over. And what that will then allow you is that those studies will allow you to translate that to a model, because that's what, as Alex has been saying, that we cannot capture, but those studies will allow us to get those two things sorted. And that then probably, once those understandings end up being there, we can do a better job, right? So I think the solution for that is not modeling. The solution for there is doing better community work and better classical epi studies, trying to understand the social determinants and determinants of things rather than just trying to project something.
Okay, thank you, Professor. So please give applause to our special to Professor Alex and Dr. Swapnil for sharing some insightful and important presentations. And also thank you for the audience for coming here and providing questions. And also hope this seminar has inspired new idea. And for you that already enrolled for the core sessions, we'll be having the sessions in the next 3 days. And hope you enjoy the session. You get all the opportunity to interact with two speakers here, and also But Tika here, they also have some facilitator for UGM that will help the session also. So good afternoon and thank you everyone. See you in the next seminar.
Our speaker. Yeah, you can have your seat. Okay, ladies and gentlemen, with the conclusion of the lecture session, we have now come to the end of the activity today. Maybe after this, we will have group picture session. Yeah? So please do not keep your seat immediately because we will take the picture together. And once again, I'm rescheduling that together with the organizing committee. We would like to say thank you and we would like to bid you farewell. Thank you and see you at the next event. Yeah. Dari depan. Okay. Okay, we will take the picture in 1, 2, 3. Okay.